Okay, we'll go ahead and get started. Again, for those of you just joining us, my name is Leanne Foster, and I am a provider outreach and education specialist here at WPS. I want to welcome you all to our session on clearing the fog, visibility on ER E&M guidelines. This is the first in a two-part series that we are doing on emergency department, emergency room services. Today is going to be focused on the policies, the billing guidelines, and the regulations for billing ER emergency department services. Tomorrow, Ashley's going to be doing an interactive session that is going to focus on rejections and denials. There'll be a little bit of a review for today, but then there's going to be an interactive activity that's going to allow you to apply your knowledge that you've gained today. If you have not already registered for that and are interested, the registration for that is still open and it will remain open until we start our session tomorrow. So that is out there and we hope to see you in that session. So what are we including in part one? So our objective today is to help provide you with a better understanding of Medicare coverage and billing guidelines for emergency department services. To accomplish that, we're going to talk about a few different things. We're going to start with what emergency services are and the Medicare coverage for these services. What do we consider emergency department service? We're going to talk about the billing requirements for emergency rooms. There are some ins and outs of it and some questions that we'll commonly get. We want to make sure we provide you with that information. Throughout, we're also going to be talking about the documentation requirements. The documentation requirements for emergency room are really no different than any other E&M service, but we're going to incorporate those into our session today. And then I'm also going to show you some available resources that are out there that'll assist you with billing for these services. So jumping right in, I want to start with an overview of emergency department services before we get to billing. So there is a definition of emergency room services, and this is important. It might seem obvious, but really what we do find is that we get questions on this. What's considered an emergency service? So I want to point out that an emergency department and urgent care are also not the same when it comes to billing Medicare. There is a difference. So an emergency department is a facility that it exists for the treatment of patients with emergent conditions. These are going to be unscheduled visits or there's something that needs immediate medical attention. Again, this is going to be different than an urgent care situation. The patient is going to present to an emergency department. They may present with an emergency. They may present without an emergency condition. However, if they're presenting to that emergency department and services are rendered, that would be a scenario where an emergency service has been provided. Emergency rooms are also typically attached to a hospital. They are a facility. We get the question about standalone urgent care facilities. Again, we're still talking urgent care. The other piece of this is that these facilities are going to be open 24 hours a day, 7 days a week, which is not necessarily typical with an urgent care. Not necessarily something that can happen, but not typical. Now, when we're talking about an emergency department, I want to go back to that being attached to a hospital piece. They're usually part of the hospital campus. We've all seen it where there's the entrance on the ground floor, there's the emergency department, and then there's the rest of the hospital. Oversimplifying there a little bit, but in general, that's what we're familiar with. It could include all hospitals. This would include a rural emergency hospital. Like I said, it's not including those urgent care clinics. They're just a little bit different. But it also means that we have to be really clear about, is this facility classified as that emergency department? The other thing that you need to keep in mind and that we need to talk about is the patient's status. So this has everything to do with how they're classified. Are they registered as an emergency department patient or not? It's not simply based on diagnosis. It is not based on the specialty of the provider who saw them. Oftentimes, emergency departments may have providers that are not emergency for their specialty. They might be something else. So it's not simply based on that. It's not even about where the patient physically is. And I say that because There are times where a patient might be in an emergency department, but they're actually classified or registered as being an inpatient observation. And this can happen for a couple of reasons. One of the more common ones is that there just simply are not enough observation beds available, and they are having their inpatient observation services in the emergency room. So you want to be very sure that when you're billing these that you understand how the patient was classified or registered with the hospital at the time of that service that you're billing. We've even seen questions where, or seen scenarios, and we've received questions on where a patient has been taken to surgery from the ER. It's possible they could still technically be an ER patient when the procedure is performed, if that status hasn't changed. So that's something that needs to be considered when you're billing, because it's going to impact the code that you're serving. So you need that know that to pick that appropriate code. And again, keeping in mind, and you'd hear this from me a couple of times, the service has to be medically necessary, and the service may not be for a patient with an emergent condition. It is possible for a patient to receive non-emergent care in the emergency room. So I want to talk about that for a minute. So what do I mean by non-emergent service? The patient, again, does not have to be an emergency. They may be presenting for a non-emergent service. So an example, they're presenting with a sinus infection. This is not necessarily an emergency for the patient, depending on their status. There are certainly some patients where a sinus infection is absolutely going to be an emergency, depending on what else they have going on. But they're presenting for a medically necessary service. They're presenting for an evaluation. Now, certainly in this case, if we're not classifying as an emergent, they're still going to use those emergency service codes. We'd expect to see for a scenario like that probably a lower level of service, but they presented to the emergency room or the emergency department for care, and emergency room services, they were registered, services were provided, even though their diagnosis might not be people might think of as an emergency. They are still receiving those emergency services, and they are still going to bill with those emergency department codes. Now, we also get asked about scenarios where the patient is not registered. So this is a scenario where the patient is seen in the ER, but it's because maybe they're registered in another outpatient department versus that ER, and maybe the doctor asked them to meet them at the ER for convenience. Could be convenience of the patient, could be convenience of the provider. They just need an alternative location. There's different reasons this can happen, but they're not registered as an ER patient. They didn't present for emergency room services. They are, again, part of that outpatient clinic. It's, again, that classification. If this is the case, that provider who's seeing them in the ER purely out of that convenience, and the patient's not registered as emergency department patient, they're going to use regular office and outpatient codes, because at that point, that's just the site where they saw them, but they're not actually an emergency department patient. This is going to be an important distinction. It doesn't happen a ton, but it can happen. But because new and established patient distinctions are going to matter here, and as you'll see in a few minutes, they don't matter with an emergency department service. So again, keep in mind, again, that classification of the patient, how they're registered, is going to play a big part in how services are billed. So next we're going to dig into billing for emergency department services. So we'll start with the basics. We've talked about some of them already. CPT codes 99281 through 99285 are the codes that are used to report services in an emergency department. These codes are only available for locations that are considered to be an emergency room by CMS and by the American Medical Association. So going back to that definition, super simplified version of it, we're talking about a facility that is open 24 hours a day, 7 days a week for the purpose of treating medical emergencies. Again, these are those unplanned visits, and they are typically attached to a hospital. Those are the facilities that are going to use those codes. If the patient was seen in the office, you're never going to use these codes. The other thing is the place of service that's used. Place of service 23 is the place of service that is used to bill emergency department codes. And again, I'm going to pull urgent care in here. That is place of service 20, and that is only for services that are provided in that urgent care. So there's a whole different place of service here as well. And again, I'm just going to call out that it's not based on the provider's specialty. It's not based on the diagnosis, whether or not these codes are being used. Medicare is typically only going to pay one per day unless the patient has multiple services that are unrelated that could not have been provided at that same time. So let's say you have a patient that's come in for a sinus infection in the morning. They were treated, they went home, they came in the morning. Later that evening, they slipped and they fell and they broke their arm. They're going to come in for that broken arm. Those are going to be different reasons. Obviously, they could not have had happened at the same time because in the morning the patient hadn't slipped and fallen and broken their arm yet. So that would be an example of where you might have a situation where there are multiple on the same day. The other thing that is super important here and is a little bit different for emergency services is we're not looking at new versus established patient. New versus established patient is going to be a patient who's been seen by the same provider or provider of the same specialty in the same group in the last 3 years. That's not something that we're looking at in that way for emergency department because every event is new. It's an emergency. It's not a planned visit. It's not a planned course of treatment. So that distinction is not there. I do, however, want to talk about that just a little bit. That same physician. A same physician is a provider of the same specialty, and this is going to be based on the two-digit specialty that they enroll in Medicare in the same group. And this is a reminder just because we get a lot of questions on that, and we'll talk about that a little bit later. If you've got a shift change, we'll talk about split share just a little bit. But it's the classification of what same physician means. And you'll notice, again, it's different. It's not that new or established definition, but in situations where same physician matters, this is how we define that. So choosing your procedure code. We talked about the codes that we're using for ER. Choosing your procedure code is purely based off of medical decision making. Excuse me, had a tickle in my throat. It's purely based off of medical decision making versus time. And this is because oftentimes time's going to be really hard to track in an ER as far as what time was spent on a particular patient. There's multiple patients, the doctor's seeing multiple patients simultaneously. There may be in and out with a patient, and it's not as simple as when they were admitted versus when they were discharged. It's not observation. So time is not going to be an option when you're choosing your level of service for an emergency department visit. You're looking at MDM. So that means the problems are addressed. So what problems were addressed during the visit? And keep in mind, it's generally what they're presenting to the emergency department for. Maybe some other things that they have going on may come into play, but what problems were actively addressed in that emergency visit? And it may not be everything that's going on with the patient. We're also going to look at the amount of data that's analyzed and then used in the medical decision making or determining the plan of care for that patient. And then the risk to the patient from their condition or the medical decisions for that patient, that plan of care. What are the risks to that patient in their current circumstance? This really is no different than an office or an outpatient code, but what is different is because with an emergency department service, you are purely using medical decision making. Now, we're not going to go in depth into medical decision making in this session. That is actually several trainings in and of itself. We do have some recordings on choosing your level of service from last year that are available on our YouTube channel. However, Ashley and I in May and June are going to be offering live sessions on choosing your level of service, and it'll include some basics and then taking a deeper dive in each of these elements. So stay tuned. Those will be available for registration soon in case you're interested. But the key piece here is that you're not using time because of those challenges. So CMS is only looking at these for medical decision making. Now, you're going to have situations where you may have patients that are in the emergency department over midnight. They may be coming in late at night. They've maybe been there all day, and we just not to the point of admitting them into observation or as an inpatient just yet, and they're going over at midnight. And we get questions on this. So if the service is a continuous encounter, this is still one date of service for that ER physician, and you're going to use that date of service that the patient came into the ER, or the date the patient came into the ER as your date of service. And when I say continuous, I don't mean that the patient never left the room, but the patient was never discharged from the ER. They haven't left the ER. They're still continuously in that emergency department. So again, if that's the case and it's over a midnight, it's not 2 emergency room visits, it's still 1 visit. They haven't left. But you're going to use the date of service from the date they came into that. Now, this is where that shift change comes in. And part of the reason for that comment about same provider, if you've got a shift change from one ER doctor to the next, the patient again hasn't been discharged, it's not going to be 2 separate codes. They're going to combine that documentation to select that appropriate level of code, because at that point, they're going to be considered that same provider. They're in the same group. They're probably the same specialty. And so it's not going to be 2 different providers. So there'll also be situations where there are multiple providers seeing the patient that present to the ER. So you're going to have situations where an ER physician is asking another physician to evaluate the patient for treatment. And this is going to be different than that crossing the midnight where we're just continuing their care. We're actually asking another physician to evaluate and potentially treat the patient. If that is a situation, the other doctor can use ER codes. So an example of this is that ER doctor is going to ask the cardiologist to come and see the patient. Maybe they need that additional evaluation to best treat them. Both of them are going to see the patient as an emergency department patient, unless that patient's been shifted to inpatient observation or inpatient. They can both bill an ED code based on the services they performed, and they're going to have to document their services separately. And again, we're talking about another physician from another department coming in. So both services have to stand alone, which is the reason that documentation has to be separate. Okay, so you're not going to bill for the cardiologist and include their documentation in the ER doctor's billing. The ER visit will be billed based off of the ER physician's documentation services that they provided. Another situation that you could have is an emergency sorry, my slide did not change. There we go. You could have a situation where a patient is asked to go to the emergency room by their regular physician. And what happens here is you have an emergency doctor and the regular physician seeing the patient. So there's a couple of scenarios here that we need to look at. And the first one is you have the emergency doctor and the regular physician, and the patient is being admitted. So this is that scenario. So both the ED and the regular physician see the patient in the ER. If there's an admission, kind of depends on who's admitting. So here, the emergency doctor is going to bill the appropriate emergency, so that 99281 through 285, again, based on the level of decision making that they performed for that patient. The regular physician in this scenario is the one admitting. It could go the other way around. This is the scenario that we're outlining. If the physician, the regular physician, admits them, they may have been in the emergency department with the emergency department physician, but they're the admitting physician. At that point, they are going to bill the appropriate initial inpatient visit because they're doing that admission. Elements, their services that they provided in the emergency department would be included in that initial inpatient visit. So they're going to bill that highest level of code using, in that case, their documentation from what they did in the emergency room and that admission. So those codes that they're going to use are going to be 99221 and 99223. And this is going to be, what's going to be important here too is that's in a situation, it's happening, both services are happening on the day of admission. The other example that we have is going to be a situation, same thing. You've got the emergency department doctor and the regular physician spending time with that patient in the emergency department, but there isn't an admission. They decide, nope, the patient can go home. So in that instance, that emergency department physician is sending that patient home based on the advice of that regular physician. If that ED emergency department physician, they are going to bill that appropriate code, which is that 99281 and that 99285. Now the regular physician is going to depend. So if that regular physician did provide emergency room services, meaning they came in and they evaluated and they treated that patient, they could bill for an emergency room service for those services that they provided. In that instance, you'd actually have two that we're going to be billing. But again, services have to be documented and stand alone. Now, if there were no emergency services provided, it could be that that regular physician was consulted over the phone, but no services were provided. They're not going to bill for an emergency department visit there. So it all depends on what that regular physician did for that patient in the emergency room. And it would need to be, again, documented. Next, I want to talk about consultations. We get questions on these a lot, and typically in, say, an office setting, they're just going to bill for the regular office and outpatient codes. ER visits are a little bit different. So if there's a consultation that's provided in person, that is going to be something that that consulting physician could bill as an emergency room procedure code if it's provided in person. They went there. It's similar to what we talked about before. They are being asked to evaluate and likely treat that patient. That's a consultation that they're going to be able to bill. That cardiologist situation, that's going to be the same type of scenario. Now, there are going to be situations where these consultations are going to be provided by telehealth, and there are different procedure codes in that instance. So here I'm showing you those codes. Now this is also going to be a little different because it is not based off of medical decision making. This consult is going to be the time. Remember, it's a consult, so there does need to be documentation that the consult was ordered, why it was needed, and then we're going to want to see that report of what was advised in that consultation and then how it was used. What we will be looking for then, though, are different procedure codes. Again, this is telehealth. The G0425 is going to be a consultation that's typically 30 minutes. G0426 is going to be 50 minutes, so that 30 to 49 minutes is going to be that 425. 50 minutes, you'll start getting into 426. And then when you start hitting 70 minutes for that consult, you're going to use that G0427. Again, that time will need to be documented. There needs to be a trail, if you will, in the documentation that shows the sequence of events where that consult was ordered, that what advice was given, and then how that was used, and then certainly the amount of time that was involved. With these codes, you are going to use a different place of service. This is telehealth. It didn't happen in the emergency visit. You're going to use 02 because it's going to be the patient is somewhere other than their home. So I do want to talk about procedures in an emergency department just a little bit here. The normal global surgery rules do apply to an emergency service, just like they would anywhere else. There's not any, so those, the 0, the 10, the 90 days for the 10 and the 90 are for that minor and major procedure or surgery. Those global periods do still apply. There are modifiers that can be used. Now, the first one's going to be modifier 25. We get a lot of questions on this one. This is going to be for a service that is a significant amount of work above and beyond what's typically happening for that patient in the emergency room, or it's separately identifiable. If it's a separate service, it's separately identifiable. It's not based on diagnosis code. But if you're using this modifier 25, and we do have recorded sessions, there was one that was done in December that's out on our YouTube channel, if you're interested, that takes a deeper dive and actually includes documentation examples for modifier 25. That is out there if you'd like to look at that a little bit more. But the documentation does need to support how the procedure was significant and separately identifiable. What we'll often tell people with the documentation is take out all of the parts that are the emergency room visit, take out all of the parts that are the procedure. Is there enough documentation when they're separated to support the service? And when that's the case, then that 25 could be applicable. A modifier 57 is when you'll have a situation, an ER physician is determining the patient needs a major surgery and that they're going to perform that like now. They need that. And the emergency service is going to essentially decide that this can't wait. So that is when you may use that 57 if that decision is made the day before or the day of that surgery. And that's, again, that ER physician saying, hey, you need this like right this second. 54 might come into place. This is used when the surgeon that performed the major surgery is transferring the post-op care to someone else and maybe in an emergent situation. That could happen. That is when that would be appropriate. It's just if they're not doing the both the pre-op, the operative care, and the post-operative care. They're just transferring that. It's information to us so we know what to look for. It'll also impact the payment on the procedure code because the post-operative care is being handled by someone else. Next, we're going to talk a little bit about nursing facility admissions that are happening on the same day as an emergency room department. Now, this can happen. They went to the emergency department and it was determined that they needed to be transferred to a nursing facility. And they're being transferred and admitted on the same day. And what I mean by that admission is that comprehensive nursing facility assessment, that E&M is happening on the same day. And typically Medicare is not going to pay for that comprehensive assessment and an emergency department visit on the same day because all services on that date of service are part of the reimbursement for that comprehensive nursing home facility. Now, I don't know how common this is, but it does happen. We do see it. If the patient were to have gone into the emergency department the day before they had that comprehensive assessment, then both services would be visible. This is all about it happening on the same day. Something else that does happen fairly often is whether or not you should bill for an emergency room visit or for critical care. Now, critical care is a different set of codes. They are 99291 through 99292, and there are certain requirements that are based on the patient's condition. There needs to be life-threatening scenarios. There's life-threatening conditions that are threatening one or more vital organ systems. Now, we do have separate instruction on critical care, so not going in depth on those qualifications, but you need to make sure that that patient is meeting the criteria for critical care services. The other thing is the delivery of that. It has to include high complex decision making to treat that single or multiple vital organ system that is an imminent threat of deterioration or failure. The other thing is there has to be a minimum of 30 minutes of critical care services provided before you can bill that 99291. So there might be situations where you're providing critical care, but it's not meeting the time threshold. At that point, it would be billed as that ER services. So requirements for both the emergency visit and critical care, the documentation has to show that critical care time. It has to show the change in the position, or in the patient's condition. So it could be that you have a patient that came into the ER and they crashed. Now they need critical care and it's extending past that 30 minutes. In order to bill for both, the documentation does need to support both services that were provided in full. So again, separating the two to see if you can bill for the two. Next, we're going to get into split shared services. Now, for the purpose of split shared service, that definition of same provider, that group is different. We do have additional training that'll go further into split shared if you're at all interested in that. But CMS does not define a group when it comes to split shared services. So what that means is they don't necessarily have to be under a tax ID. Typically, group is defined by tax ID for all of other services. The entities involved are going to define that group. So it could be that one thing that we do often see is that we have a group of cardiologists that are maybe contracting with a group of nurse practitioners and they're hospital based and they're working together to provide services for the patients. With ER visits, it can look just a little bit different, but essentially the point here is that the two entities or the individuals that have agreed to be a group for the purpose of split shared services are entering into an agreement. It is typically a contract, and then that contract's not only going to identify the individuals that are agreeing to participate in this group, but also how they're going to be reimbursed. For split shared services, you're only billing for the provider that provided the substantive portion, and for emergency room visits, we're looking at that substantive portion of that MDM, because remember here, time's not a factor when you're billing emergency room. So we have to know how the other provider involved in those services are going to be reimbursed. And that is something that does need to be kept on file if CMS or MAC asks for that. So when they're submitting with the services for the practitioner that provided that substantive portion, they're going to use modifier FS. That's going to let the MAC know that this is a split shared service. There were more than one provider, and then the documentation is going to reflect that. So before we get to questions, I do want to point out some of the resources that we have available to you. Emergency room or emergency department services are outlined in Chapter 12, and it does have several sections that you'll want to look at. Section 30.6.11 and then Section 190.2. And I'm going to go ahead and go out to those. And if you go out to the CMS website, there's a couple of ways to get here. You can go under the Medicare drop-down and go to Regulations and Guidance. You can also go down here. They do have a card that's for manuals, forms, transmissions. I'm going to the internet-only manuals, and you can get there both ways. From there, you're looking at the Medicare Claims Processing Manual, which is 100-4. Sorry, clicked the wrong button there. And then you're going to go into Chapter 12. And this is where you're looking at those sections that I have there for you, which is going to be section 30.6.11, which is right here. And there's not a ton here, but there are some scenarios here. It's going to go through what we discussed today, but there's also some billing scenarios that are here. There's some conversation about non-emergency services. The nursing facility visit services are here as well. Also, section 190, and I'm just going to go back to the top. I pardon the scrolling. And then 190 is where you're going to find information specific to emergency department telehealth visits. So that is out there for you. The other thing is going to be our evaluation and management services guide that has some good information out there for you. I've also included a list of the telehealth services so that you have that, and then Medicare and CCI webpage. For instance, that nursing comprehensive assessment, that's considered a bundled service. That NCCI webpage will help with that. WPS has a couple of resources that'll be of assistance as well. We have the correct billing of split shared services. We talked about that just a little bit. There's more information there about those contracts and who's going to bill for those services. And then I've also included a link to our evaluation and management services YouTube playlist. I mentioned a couple of recordings, split shared, choosing your level of service. Those are all available out on that YouTube. All right, so with that, I'm going to check in with Ashley. Ashley, what questions do we have?
Hi, Leanne. We do not have any unanswered questions in the chat.
All right. Thank you, Ashley. And those of you, those chat questions, I will create a follow-up document. I will send those out to everybody so that you have those. Ashley and I do try to answer those questions in the session as best as possible so no one is leaving with a question unanswered. If you have any questions for the next 7 days, you can certainly send that to our education mailbox, and Ashley's going to throw that email address back into the chat so that you have that. When you send that, just like with technical issues, you want to throw in the title of today's session. You could put emergency room visits. That's just going to let the individuals that are monitoring that mailbox know they need to get that to Ashley and I so that we can get you an answer, get you a response. If it is claim specific about something that's currently in process or is denying, that is something that does still need to go to customer service because they'll be able to access that claim and better advise you. So in a few minutes, you are going to receive an email that is thanking you for attending. Don't delete that without taking a look at that. It serves a couple of purposes. First, at the beginning, we did let you know that you would have the opportunity to provide us with some feedback on how we did today, what we could do better, and of course, any topics you'd like to see in the future. You've got a couple of ways you can take that. Ashley's putting a link into the chat. You're also going to have a link in that email that you receive, and there's going to be a pop-up box when you leave this session. That pop-up is not malicious, it's not spam, it's not dangerous. It's just telling you that you are leaving our webinar software and we're taking you right into the survey if you care to take a few minutes for that. The other important piece of this, if you are attending today for continuing education credits, this is your certificate of achievement that can be submitted to your accreditation or certification body to give you credit towards those continuing education credits. We don't issue the credits, but again, we will issue contact hour certificates so that you have that. With that, I want to check in one last time. I think I saw something come in the chat. Ashley, do we have any questions that came in?
We did just have one come in, which is, they say, just to clarify, same beneficiary, same date of service, returns to the emergency department for same primary problem, only bill one ED facility charge for highest level of care, correct?
That is correct, and that's an excellent question to clarify. I gave the scenario before about only paying one ED service in a day. unless they could not be addressed at the same time. The scenario I gave was they had a sinus infection in the morning, and later in that day they slipped, fell, and broke their arm. Those are two services that could not have been performed at the same day. But if you switch that, they came in for the sinus infection in the morning, they came back in the evening for the sinus infection, you are correct, is that you would only bill the one facility charge for the highest level of care. Excellent question. Thank you for that. Anything else, Ashley?
That was the last question.
All right. Well, with that, we are going to give everybody back a little bit of time in their day, and I want to thank you all very much for attending. On behalf of Ashley, myself, the entire Outreach and Education team, we appreciate you taking the time to attend these sessions, and we hope that you find those beneficial. Everybody's super busy, and we know that that can be kind of precious time and hard to carve out. So with that, we hope to see you in our session tomorrow. Remember, Ashley's going to have that interactive session on emergency department visits. So if registration is still open, if you haven't already registered, you still have time to do that. And with that, you may now disconnect, and I hope you have a great rest of your day.